to introduce our next two speakers within this COVID, patient safety, and the future session, who will both focus on key insights and lessons learned for enhanced patient safety. I am pleased to introduce a good friend and ally of AAKP's Dr. Priti Patel. Dr. Patel is a medical officer for the Centers for Disease Control and Prevention. AAKP first had the pleasure of working with Dr. Patel during her prior time leading the CDC's Making Dialysis Safer coalition. Her dedication to ensuring kidney patient safety inside and outside of the dialysis facility led AAKP to recognize her as one of the first civil servants to receive the AAKP National Patient Engagement and Advocacy Awards for public service. It is an honor having her join us to share CDC updates on COVID and the agency's vaccination program. Dr. Patel, I turn it over to you.
Hello, and I'd like to thank AAKP and JW for inviting me to be part of this very important summit. I'll be talking about COVID-19 vaccination in dialysis centers and a unique partnership between dialysis providers and public health. For this presentation, I'd like to take us back in time a little bit. As many of you may remember, in mid to late 2020, cases were rising and the situation felt bleak at times, particularly for people with high-risk medical conditions. There were some things that we knew at this time and other things that we didn't. By early on in the pandemic, we knew that people with certain medical conditions were at high risk for severe outcomes from COVID-19, and that includes people with chronic kidney disease. We didn't exactly know if SARS-CoV-2 was more likely to be transmitted in dialysis centers, but we suspected that that could be the case. So patients who are on dialysis didn't have the option to just stay home to reduce their risk of exposure. They still needed to travel to go to dialysis 3 times a week and risk exposure to SARS-CoV-2 during transportation to and from dialysis. And then once in the clinic, risk exposure because of the difficulty in physically distancing patients and others within the dialysis center. So these are just some of the factors that cause dialysis patients to be at heightened risk of serious outcomes from COVID-19. This paper didn't come out until 2021, but shows really interesting information about excess death estimates in patients with end-stage renal disease. So the authors here attempted to estimate the number of excess deaths in patients with end-stage renal disease attributable to COVID-19. And what you see in the graph is 2 different lines. The dashed blue line demonstrates the predicted number of deaths over different time points, assuming that the pattern that had occurred in previous years would continue in 2020. The dark black line shows the actual or observed number of deaths that occurred during that same time frame. And you can see that the gap between the black line and the dashed blue line in the yellow box in 2020 represents the excess deaths that are attributable to COVID-19. So during just a 7-month time period between February and August of 2020, there are estimated to be between 7,000 and 10,300 excess deaths among end-stage renal disease patients attributable to COVID-19. These data are not new to people. These are prevalence estimates of end-stage renal disease by race and ethnicity, and you can see here dramatic disparities by race and ethnicity. If we look at the prevalence of ESRD within Black and African Americans compared to American Indians, Alaska Natives, Asians, and whites, and also the end-stage renal disease prevalence among Hispanics compared to non-Hispanics. So we know that these communities of color were particularly hard hit by COVID-19, and we knew that in early 2020 as well. So these disparities were overlaying on top of the increased risk of severe outcomes related to underlying medical conditions and related to the potential risk of increased exposure from healthcare. All of these different factors were intersecting among people with end-stage renal disease to increase their risk dramatically and raise our concerns about their need for additional measures to protect them. This slide shows a number of different events that occurred with respect to COVID-19 vaccines and the Advisory Committee on Immunization Practices. So this is a timeline mostly of events in December of 2020. So by late 2020, it became clear that there were vaccines on the horizon, which was great and hopeful news. It was also clear that the initial demand was likely to exceed supply of vaccine. So given that on December 3rd, the ACIP put out an interim recommendation for allocating initial supplies of COVID-19 vaccine. And in that recommendation, they identified what they called a phase 1A group for prioritization of initial supply of COVID-19 vaccine. And that group consisted of healthcare personnel and also long-term care facility residents. On December 13th and 20th, respectively, the ACIP recommended use of Pfizer-BioNTech COVID-19 vaccine and also Moderna COVID-19 vaccine following each of those vaccines authorization by the FDA. And on December 22nd, the ACIP updated their interim recommendations for allocation of COVID-19 vaccine. In other words, they updated the recommendation that they released on December 3rd. In that update, they expanded the different phases that were recommended to be prioritized for allocation of COVID-19 vaccines. And in this table, you can see that phase 1A remained the same and included healthcare personnel and long-term care facility residents, as I mentioned. In the right-hand side of the slide, in those columns in the table, you can see the estimated number of people in millions who belong to each of those groups. And then they added phase 1B, which included frontline essential workers beyond healthcare personnel, and also persons aged 75 years and up. In phase 1C, they added persons who are aged 65 to 74 years, persons aged 16 to 64 years with high-risk medical conditions, and essential workers who were not recommended for vaccination as part of phase 1B. And then finally, phase 2 consisted of all persons aged 16 years and up who were not otherwise recommended for vaccination in those prior 3 categories. So this meant that dialysis patients and people with end-stage renal disease were not specifically recommended to be included in phase 1A or phase 1B unless they had other characteristics that, such as age, or long-term care facility residents that would have put them into one of those higher prioritized categories. Instead, dialysis patients and people with end-stage renal disease fell into category 1C with a total of 129 million people. And this led to a lot of concern about delays in potentially getting access to the vaccine. It was a framework that was created to help guide jurisdictions and health departments' decisions about how to allocate vaccine. But ultimately, health departments and jurisdictions had the ability to prioritize beyond this framework and could make their own decisions based upon what were the priorities for their jurisdiction and needs. Given the concerns about when dialysis patients would be able to access COVID-19 vaccine, there was a lot of discussion within the dialysis community and within the federal government about the need to create another channel for dialysis clinics to be able to receive COVID-19 vaccine. So the standard means by which vaccine was being distributed early on in the vaccination effort was federal government distributed supply of vaccine to jurisdictions and health departments, and those health departments would then further distribute vaccine per their prioritization within their jurisdictions. So there began to be discussions about the possibility of a federal dialysis partners program whereby dialysis clinics could directly access federal supply of COVID-19 vaccine. And the dialysis community helped tremendously to raise awareness about the need for this and the importance of reaching this patient population with COVID-19 vaccine. In addition, there were a lot of conversations about the need to stand up this program and the timing of standing up this program. And in the interim, when it became clear that this program would not be stood up immediately, we began to communicate with our jurisdictional public health partners to encourage them to allocate their jurisdictional supply or allocation of vaccine to dialysis centers and the important reasons for doing that. With a great deal of discussion and planning and advocating for this to happen, in March of 2021, the Biden administration announced a historic investment to expand access to COVID-19 vaccines and to build vaccine confidence in hardest hit and highest risk communities also known as the COVID-19 Health Equity Plan. And as part of that, they finally gave the green light for the partnership to vaccinate dialysis patients to launch, which was incredibly exciting. And so part of the approval and the entire rationale for this program was not just to reach a high-risk population due to their underlying medical conditions, but also to improve health equity. Next, I plan to share some results of our evaluation of this program and its impact. In this program, Fresenius and DaVita clinics received COVID-19 vaccine directly from the federal government, and they also facilitated distribution of vaccine to other dialysis provider organizations. Because the data reporting requirements were different for the large dialysis organizations versus the smaller dialysis organizations, we only included data from Fresenius and DaVita in this evaluation. There were approximately 5,100 participating Fresenius and DaVita clinics included in this evaluation. This slide shows the number of persons receiving at least one COVID-19 vaccine administered in a dialysis clinic, either a DaVita or a Fresenius clinic, by the week administered for the time period of our evaluation, which started December 1st, 2020 and went through June 13th, 2021. You can see here the bars are colored in three different colors. The medium sort of teal color in the middle that represents the biggest portion of the bars are patients who are vaccinated in dialysis clinics. The dark green color represents staff, excuse me, and then the light aqua color represents people other than patients or staff. So this might be transport personnel, this might be caregivers, it's anyone other than staff in the clinic and patients. And what we gleaned from this is that there are many initial waves of vaccinating individuals prior to the federal allocation, and the way in which we understand this pattern prior to the federal allocation is that the numbers of people who were vaccinated prior to that federal allocation were limited not by willingness to receive vaccine or need, but were limited by the supply that was made available to dialysis centers. Once the federal allocation was initiated, we see a spike in the number of vaccines administered in dialysis clinics, and we see that that rapidly drops off, meaning that dialysis provider organizations were able to rapidly mobilize the vaccine, distribute it to the people who needed it in a variety of clinics across the country, and then that need dropped off pretty rapidly because they were able to mobilize and get the vaccine to those people who needed it very quickly. We also noted that there is ongoing need among healthcare personnel or among staff within the clinics throughout this time period. So even though healthcare personnel were prioritized very early on to receive vaccine, the need was not met early on. The need continued even until the time when the federal allocation was initiated. This slide shows patients undergoing dialysis who received at least one dose of COVID-19 vaccine by race and ethnicity. So these are, this table represents all patients within the dialysis clinics that were participating, Fresenius and DaVita dialysis clinics that were participating in this program at two different time points. And we assessed their vaccination status as defined as partially or fully vaccinated. And as you can see in the two boxes, we looked at this at two different dates, on March 28, 2021, which we could effectively consider the pre-federal allocation time period or time point, and then June 13, 2021, which is the end of the evaluation period. In the beginning of the evaluation period, we see that Black patients had the lowest vaccination coverage of 45.2%. Hispanic patients and white patients had similar vaccination coverage of 51 to 52%. And then Asian patients had the highest vaccination coverage of 60%. After the federal allocation of vaccine, this pattern changed a little bit. So Asian patients still had the highest vaccination rate of 74%. But Hispanic patients' vaccination coverage had increased dramatically to 69.5% and actually exceeded the vaccination coverage among white patients. While Black patients still had the lowest vaccination coverage of this particular subset that I'm highlighting here, the gap between the vaccination coverage among Black and white patients had reduced between the first time point and the second time point after the federal allocation. This graph might show this pattern a little bit more clearly. So we see here that multiple different lines showing vaccination coverage over time relative to the federal allocation. The green line represents all healthcare personnel overall vaccination coverage. The black line shows all patients overall. And if we just look at those two for a moment, we see that the vaccination coverage among healthcare personnel overall started to climb earlier than that among patients, which makes sense because this group was prioritized earlier to receive vaccine compared to patients. But ultimately, on the tail end of this graph, we see that both of these lines plateau. And interestingly, the vaccination coverage among patients ends up being higher than that among staff. And this is an area of great interest and something that we need to continue to work on. The other colored lines, light blue represents the vaccination coverage among non-Hispanic white patients. The darker blue represents that coverage among non-Hispanic Black patients. And then the gray line represents vaccination coverage among Hispanic patients. So if we look at the gray line for a moment, we see that it tracks somewhat with the other subgroups of patients right until about the time when the federal allocation was initiated. And then it suddenly jumps up and exceeds the vaccination coverage among non-Hispanic white patients, and it remains much higher than any of those other groups that are included in this slide. While it's harder to see the light blue line, which is non-Hispanic white patients, compared to the darker blue line, which is non-Hispanic Black patients, you can see that there is a gap that exists between the vaccination coverage in those two groups earlier on, and that gap narrows as time goes on. And after the federal allocation, that gap is much more narrow than it had ever been prior to that. Lastly, we wanted to share some information about the percent of vaccinated patients. This is all patients who are vaccinated among DaVita and Fresenius participating clinics who received a COVID-19 vaccination in a dialysis clinic versus other location by race and ethnicity. So essentially what we're looking at here is among those patients who were vaccinated, where did they get vaccinated? Was it in the dialysis clinic or was it another location like a pharmacy or somewhere else? So overall, among all patients, just over half received their COVID-19 vaccination in a dialysis clinic compared to another location. And when we look at that broken down by different race and ethnicity categories, we see that non-Hispanic Black, non-Hispanic Asian, and Hispanic patients were much more likely to receive their COVID-19 vaccination in the dialysis clinic compared to non-Hispanic white patients. Impressively, the dialysis clinic was the location of vaccination for 62.2% of Hispanic patients compared to only 42.5% of white patients. And clearly, the federal allocation of vaccine made this a greater possibility of being able to receive the COVID-19 vaccine in the dialysis clinic from a trusted source and in a convenient location. To summarize our conclusions and lessons learned, dialysis providers demonstrated they were able to rapidly distribute and administer COVID-19 vaccine. This was a unique partnership between public health and dialysis provider organizations, and that partnership, together with the federal allocation of COVID-19 vaccine, increased our ability to reach a high-risk population and contributed to reductions in racial and ethnic disparities and vaccination coverage. We learned that dialysis clinics are an important location for vaccination, as half of all vaccinated patients were vaccinated in the clinic. And this location had greater importance for Black, Asian, and Hispanic patients compared to white patients. In the future, we feel strongly that public health agencies and health departments should partner with dialysis providers, and vaccines should be made available to dialysis centers for on-site administration. There are a number of ongoing needs and opportunities for improvement. For example, there's a bivalent COVID-19 booster vaccine on the horizon, and for that vaccine, we will need to reach the same high-risk patient populations that we've always strived to provide vaccine to. There's also opportunities to increase staff vaccination coverage and confidence, and that will likely have indirect benefits to patient vaccination. Ultimately, we believe this program had substantial public health impact that's important for policymakers and others to understand. This was an incredible effort that had many, many contributors to the program itself and to the information that I presented to you today, and I'd like to thank all of them for their contributions. And thank you for your attention today.
Thank you, Dr. Patel. We appreciate you taking the time to share your insights and experiences.